patient, a wrestling coach, comes to me after complaining of immediate deep shoulder pain after demonstrating a takedown of an opponent. The first few history questions that I ask are, what are your chief complaints? So why are you here? When this happened and how did this happen? Can you point with one finger where the most point of pain is, and with the second finger, can you point to the other point of pain, the second most point of pain? Can you tell me if you had any swelling when this injury first occurred, or do you have any swelling now? So mobility of swelling. On a scale of 1 to 10, how bad does this hurt? 10 being you have to go to the hospital right now. Have you ever had this injury before? Do you wear braces for this shoulder? Do you have any numbness, paresthesia, tingling going down your arm? Is it sharp, dull, achy? Did you feel any popping, clicking? Did you hear a crack? Are there any motion that you can't do? Can you lift up your arm? Are there any motion that are hindering you, or anything that you can't do in your daily life? So those will be my history questions. After getting a full history from the patient, if they came to me and told me that they were in too much pain or they couldn't do certain ranges of motion, then I would not proceed to do any ranges of motion or MMTs or special tests that would cause so much movement. Some observations that I would be looking for is when they walked into the athletic training room, I would be looking for their demeanor, and I would also be looking at their posture to see if they're holding their arm or like leaning more towards one side because of the amount of pain that they're in. I would be looking for any edema, effusion, ecchymosis, abrasions, any lesions, any open wounds, any scarring, obvious deformities, maybe of the deltoid. I wouldn't be looking for anything else. Some palpation that I would do, I would just go over the deltoid first, all aspects, so mid-deltoid, anterior deltoid, and posterior deltoid. I would go within the glenohumeral joint, just because of the deep shoulder pain. I would also be going over the biceps tendon, see if that elicits any pain. Go across the clavicle just to find the AC joint. See if there's any pain there. Go down, find the coracore process, see if there's any pain there. Again, if they're in too much pain or they told me that they couldn't perform any types of range of motion past a certain degree or they couldn't perform them at all, I would not be doing this. But I would have her do flexions, so you can put your palm up, go towards the ceiling all the way. You stand up. And you go backwards, so extend as much as you can. Let me know if that would elicit any pain. And go out this way. You let me know if that would elicit any pain. I would do some mobility of her shoulder just to see where the pain is. So I would do a focus 1. Can you lie down on your back? I would do an apprehension test. And then relocation and relief. Okay, you can sit back up. Now I'll do some labral tests. So I'll do the anterior side. Put your hand on your hip. I'm going to axial load into the joint and push back against me. See if that will elicit any pain and an O'Brien's. So put your hand here, empty can. Don't let me push you down. Don't let me push you down. And then open palm. I could also do any rotator cuff or biceps tendon special test just to rule those out. So my differentials are a rotator cuff strain and biceps tendon tear or rupture. So first I would do an empty cam. Go here. You're gonna go all the way up against my resistance, okay? Good. All the way, all the way. Okay, now drop arm. Bring it up, don't let me drop it. Okay, now bring it passively up. Now you're gonna bring it down slowly. If at 90 she couldn't hold it and she just dropped it, I would know that would also be a positive. Since I will do the biceps tendon test. So I would do a Jorgensen's. Put your hand in your lap. You're gonna turn out like this against my resistance. Go ahead. Put your arms like this. Make muscles. If any of those elicit pain, then I would know she had a labral tear. And for any of the differential special tests that I did, such as Wood Wings and Jorgensen's, if those came out positive, then I would also have to rule out a biceps tendon rupture. The modalities that I chose were interferential, so IFC. I would do 70 to 150 pulse duration and 80 to 125 pulses per second, so the frequency. I would do it at a sensory level, so no muscle contraction, and I would do this for 15 to 20 minutes. Some exercises that I could have her do. Can you lay back? If there was a sustainable labral tear and she did need to be referred out before any of the range of motions or MMTs were done and she couldn't do it at all, then she would need surgery, so I would refer her out post-op first to get an MRI and a surgery, then she would have surgery for it. But after, she would then do exercises such as proprioception, which is just balance. I would have her with a small weighted ball, and I would have her go up to down or where the painful arc would stop. I would have her do 3 sets of 15. I could also have her do arm climbs. So you would essentially be doing this, going all the way up with your arm. That would also be 3 sets of 15, and then as she progressed, she could do more resistance, so there would be a resistance band in this arm here, and it would be connected to a wall, and she would stay stiff and take 2 steps out and come back in and out. 3 sets of 30.